بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. في البداية أحب أرحب بحضراتكم. اسمي خالد الصياد، استشاري علاج الأورام في جامعة مونستر في ألمانيا، وحاليا رئيس مجلس إدارة جمعية جسر للتبادل العلمي والاجتماعي. جمعية جسر هي اختصار لكلمة German Egyptian Social and Scientific Relationships. هي جمعية غير هادفة للربح، تأسست هذا العام في يناير في ألمانيا. الهدف الأساسي من إنشاء الجمعية في ألمانيا هو دعم العلاقات الاجتماعية والعلمية بين البلدين. قبل البدء في فعاليات البرنامج بعد الافتتاح اليوم، ستلقي الدكتورة رانيا العيسوي، هي المسؤولة عن برنامج التعليم الطبي المستمر في دار الحكمة نقابة أطباء مصر، كلمة عن البرنامج المشترك وأهدافه. تفضلي دكتورة رانيا، الكلمة معاكي.
أحب أرحب بالسادة الأطباء اليوم في أول مجموعة المحاضرات اللي مقدماها جمعية جسر، وهي جمعية من بعض الأطباء المصريين بالخارج بألمانيا والبلاد الأوروبية وبعض الأطباء الأجانب، بتحاول إنها تمد جسر ثقافي بينهم وبين زملائهم الأطباء المصريين داخل بلدنا، ونقل جميع الخبرات والمعلومات الحديثة عن طريق محاضرات متميزة جدا بذلوا مجهود ان هم يحضروها، وان شاء الله يستفيد بها جموع الاطباء. واحب اشكر طبعا الدكتور خالد الصياد لتعبه ومجهوده في تحضير هذا البرنامج، وان شاء الله يكون في الافادة للجميع. بالتوفيق ان شاء الله.
شكرا دكتورة رانيا. ننتقل الآن لمحاضرة اليوم والبرنامج الأساسي. النهاردة هيكون عنوان المحاضرة Aggressive non-Hodgkin lymphoma and the role of radiotherapy. سيلقي محاضرة اليوم أستاذ دكتور بروفيسور جورج ميخائيل، أستاذ علاج الأورام في لندن. دكتور جورج ميخائيل مصري الأصل وبيتكلم اللغة العربية بطلاقة، ولكن نظرا لوجود ضيوف أجانب اليوم في اللقاء سأقوم بتقديمه باللغة الإنجليزية. المحاضرة عبارة عن 45 دقيقة، وبعد كده ممكن لو في أي أسئلة ألقيها الدكتور جورج وسأقوم بالرد عليها. Good morning everyone and welcome to today's meeting. Professor George Mikhaeel will talk today about non-Hodgkin lymphoma and the role of radiotherapy. For those who don't know him, Professor George Mikhaeel has been graduated from Egyptian universities and trained in clinical oncology in Guy's and St. Thomas Hospital, University College London Hospital and Mount Vernon Hospital before his appointment as a consultant in 2001. In addition, nowadays he is working as a professor for radiation oncology in King's College in London. His research interest is focused on advanced radiotherapy techniques and the use of imaging in lymphoma. Moreover, he published the first UK study pioneered the use of early response assessment by PET scanning in lymphoma. Professor Mikhaeel has organized several national and international meetings and lectures in more than 15 countries and has numerous publications in field including international guidelines. He is also a founder of the International Lymphoma Radiation Oncology Group, LROG, and a member of its steering committee. He also chaired hematological track in American Society of Radiation Oncology, ASTRO annual meetings, and active reviewer in ASTRO and member of Royal College of Radiologists. Please welcome Professor Mikhaeel. George, you have the floor.
يشرفني جدا اني اكون جزء من هذا النشاط. I will just try and share a screen now. Can you see my screen?
Yes, very.
Excellent. Okay. So I'll speak in English. When we come to questions, I don't mind at all if you find it easier to ask the question in Arabic, and we'll translate and talk in English again. So today I will be covering the role of radiotherapy in high-grade aggressive lymphomas in the 21st century and in 2021. Because diffuse large B-cell lymphoma is the most common category, most of the talk will be referring actually to diffuse large B-cell lymphoma, and I hope that's okay with you. So before we get into details, I'd like to make a very important distinction between diffuse large B-cell lymphoma and Hodgkin's lymphoma. That one of the problems in our thinking usually is that we extrapolate from Hodgkin lymphoma into diffuse large B-cell lymphoma, which is a very different disease. And that's usually in relation to the risk of second malignancy and the desire to avoid radiotherapy in young people. So it's important here to just highlight that this is not a very accurate way of dealing with DLBCL, and DLBCL is really a very different disease. It's less curable than Hodgkin's, it's more deadly. It affects a different age group, an older age group, which has less tolerance to prolonged chemotherapy and less salvage options, and they also have less risk of second malignancy. So this is just a graph to see, to show the incidence of diffuse large B-cell lymphoma, and the peak incidence being in the 70s, at least in Europe and North America. So the first point I'd like to make is that diffuse large B-cell lymphoma is much more lethal disease than Hodgkin's lymphoma, and the main concern in DLBCL is curing the disease. So the way I will address the subject is really ask a series of questions. The first one, there's no doubt that systemic therapy is the main line of treatment for diffuse large B-cell lymphoma. It's chemoimmunotherapy. That's the main line of treatment. The question really is, does the addition of radiotherapy add to the outcome? And in other words, is systemic treatment enough? And if the answer is definite yes, then there's no need for radiotherapy. But if there is an incidence of relapse, then the addition of radiotherapy may be able to reduce that relapse. So I think the first case is to look at, is there a room for improvement? Then if there is, then there are two questions: the cost-benefit analysis, and the cost here is the toxicity, not the monetary cost. The radiotherapy benefit needs to be assessed, which cases benefit, and what would be the toxicity of adding radiotherapy in that case. And the benefit has to exceed the toxicity of radiotherapy for us to recommend radiotherapy in the specific situation. So moving on, I'll pick up the toxicity first, and particularly the second malignancy risk, so we can be very clear about that from the outset. There are 3 publications that addressed the second malignancy risk in non-Hodgkin lymphoma, and the conclusion from these 3 studies are that half of patients die before they have lived long enough to develop second malignancy. That's very different from Hodgkin lymphoma. And also the incidence of any second malignancy, whether it's radiotherapy or chemotherapy, is only in patients who lived more than 10 years after the treatment, as you would expect. But actually, when you look at the details, there was no increased risk with radiotherapy in these studies. It may well be that the use of radiotherapy is not that common, and therefore the risk was not apparent. But the fact is, we do not have strong evidence of increased risk of second malignancy in diffuse large B-cell lymphoma. So then moving back to the initial question, which is there any room for improvement? We know worldwide that the gold standard remains R-CHOP, and it when rituximab was added to CHOP, it resulted in a significant improvement, but the long-term remission remains to be around 60 to 70% in clinical trials. And in population-based studies, it's actually lower than 60 to 70%. We also know that after rituximab addition, salvage treatment became less effective. In other words, relapse after R-CHOP defines a worse prognostic group. And the disappointing fact is there's not been a significant improvement since R-CHOP was introduced more than 20 years ago. So this is the original study, the GELA study that introduced R-CHOP, and the very long-term follow-up from it shows the difference is maintained. So it's a real difference. It doesn't disappear with time. However, you can see where the curve is drifting down with a very long-term follow-up. And this is the comparison between a clinical study. This is the British study that compared R-CHOP 21 to R-CHOP 14. The two arms are here. And you see that the 3-year follow-up also suggests PFS in the early 70s. You go and look at a population-based study, for example, taken here from British Columbia and Canada, and you find that it's actually in the early 60s. So there's about a 10% drop when you start looking at population-based outcome compared to a clinical study. So a third of patients is not cured with R-CHOP. This is the CORAL study, which was looking at salvage options after rituximab or not. And it became very clear that patients who never had rituximab in initial treatment has the usual outcome with stem cell transplant as per the initial Palmer study, but people who had prior rituximab have much lower outcome with salvage treatment. So this is the point about salvage being less effective after rituximab. So if you put all this together, what do we expect if we take a group of, say, 300 patients with diffuse large B-cell lymphoma? The primary treatment will cure about 2/3. That's 200 cured. But then that leaves us with about 100 relapse happening. At the point of relapse, usually about half only are eligible for autologous stem cell transplant because of age and comorbidities. So these will not be curable here. And those who are eligible for autologous stem cell transplant may go on to have salvage chemotherapy. And again, half of them will respond to that salvage chemotherapy. And then they go on to have a stem cell transplant. And of those, around 10% are cured. But all these in orange are patients who will eventually die from their lymphoma because there's no effective salvage. So this is out of 100 relapse, about 10 are cured and 90 died from lymphoma. Now, CAR T-cell therapy now came along in the last few years, and it probably would cure another 5 to 10% of those who are in this group. But again, the 10% cure might be 15, 20% overall, but the majority of relapses will die from disease. This is a little bit of a disappointing slide because it shows so many studies done to try and improve on R-CHOP, and none of them worked. And I'm aware that you will have a detailed talk about chemoimmunotherapy later in the course. So, is there room for improvement? I think we can see that 30 to 40% are not cured, and salvage is not that effective. So which cases can we define which cases benefit from radiotherapy? And I think in the last few years, our understanding has improved in terms of selecting patients who may benefit from the addition of radiotherapy. So which cases benefit from radiotherapy? Divide that by first-line treatment and salvage treatment. In the first-line treatment, you can add radiotherapy for two purposes. One is to reduce toxicity, to reduce the length of chemoimmunotherapy, and the other one is to improve the outcome. The example of that is early-stage disease, where you might give a short course of chemoimmunotherapy with radiotherapy. And the other example, improved outcome, would be after a full course of R-CHOP. And there are a number of indications, for example, bulk, extranodal sites, skeletal sites, testicular disease, and residual masses. In the salvage setting, radiotherapy could be used for incomplete response on PET, and cases where the relapse is localized to one area, and also more recently bridging to CAR T therapy. And I'll try and show some examples of all of these. So picking up bulk, which is really one of the most common indications of radiotherapy nowadays, this is one of the early studies that is a German study that showed the benefit of radiotherapy in bulk. It was in patients above the age of 60. So this is an older patient group. And there were 4 different arms with similarities. So 6 versus 8 CHOP14, and then the addition of rituximab or not to CHOP14. And the winning arm out of the 4 was the 6 cycles of CHOP14 plus 36 grade to bulk or extranodal sites. What our German colleagues did was extended the study, removing radiotherapy to see what the outcome would be like. So this has been labeled as Recover 60 no radiotherapy. And it's the same arm, but extended without radiotherapy. And that's the comparison here. If you just look at the progression-free survival, it was 62% versus 88% in those who had radiotherapy. So there was a drop of 26% in PFS when radiotherapy was removed from the protocol. And in overall survival, surprisingly, that showed 25% difference. That's perhaps a reflection of the age group we were talking about in this study. So the question really is, does this 25% difference, I mean, if this was a difference for a drug, the newspapers would be talking about it the next morning. But the question really is it just because this group is not eligible for stem cell transplant? So the Germans, again, did a very good study. Unfortunately, it's not published fully yet. And that's the Unfolder study. And that's all age groups, and in fact, mostly younger group, where the randomization was between CHOP14 and 21, with radiotherapy in both cases, but also 2 other arms similar to these without radiotherapy. And after an interim analysis of 443 patients, they actually stopped the study because they saw the same drop in a randomized context when you remove radiotherapy. So at 2 years, the 86% you get dropped to 66%, and at 3 years, the 81% dropped to 65%. That's 20 and 16% differences. Just remember that figure with me to come back to later. The 80% or above, and nearly 86 also for radiotherapy combinations. So the problem is we do not now have an answer to the question, but which is, okay, we have a bulky initial disease, but it achieved a complete metabolic response. If the bulky site is CMR on PET, do we still benefit from radiotherapy? And that's a problem, because we wanted to answer that question in the UK in a randomized study where we take those who have complete metabolic response and randomize them into radiotherapy versus not. And sadly, with 2 rounds of application for funding, the trial was not successful in obtaining funding. So that trial really needs to be done still, but it's not happening anywhere in the world right now. So the question remains open. On the positive side, the IELSG 37 trial is looking at the primary mediastinal B-cell lymphoma and trying to answer that question for us. And this is important because this is the group that tends to be young and tends to be females, and it's mediastinal irradiation. So it's actually the ones that, if it proves to be a positive study, in other words, the PET negative patients who went into observation without radiotherapy did well, then we can stop irradiating this disease in young people in the mediastinum particularly in females. The study has been completed. There was an initial abstract in Lugano in the summer, but looking just at the outcome of the various regimes and suggesting that the R-CHOP had the lowest CMR rate, but we do not have any results on the randomization yet. This is just going back to a very old study, just as a proof of principle, if you like. We're asking that question, actually. If you had a bulky mass and you achieved CMR, complete metabolic response on PET, does radiotherapy add anything? This study answered the question about CR. So this is an old study before rituximab. It was R-CHOP times 8. And if you had CR, after 8 cycles, you went into observation in arm A. This was randomized. In arm B, if you had CR, that's no residual mass. You still received 30 gray. And interestingly, there was a difference between observation and radiotherapy. So it suggests that even if you had disappearance of the initial mass, the radiotherapy still reduced the relapse rate. And this study is this slide is a collection of 3 published series from different institutions looking at radiotherapy after complete metabolic response, retrospective, non-randomized, so we can't make too much of it, but there is a general trend to improved outcome if you added radiotherapy. The final piece in this that I'd like to discuss is this interesting study from the MD Anderson, where they took 300 patients who did not have radiotherapy. They had only chemoimmunotherapy, and all of them had PET negative, and looked at their outcome by the presence or the absence of a residual mass. And what they found that if there is a residual mass, remember, this is a PET negative residual mass. It's a complete response. Anyone who had a residual mass had a slightly worse outcome. And they found the cutoff of 2 centimeters for the residual mass to be the one that makes the difference. In other words, if it's 1.5 centimeters, it didn't make a difference, it's the same. So anything that was above 2 centimeters showed worsened outcome in this particular series. It's retrospective, but it's relatively clean, no radiotherapy, chemoimmunotherapy, all PET negative. It's an intriguing question about residual masses. This is the latest publication in this particular question, which is earlier in the year in February 2021, that looked at the British Columbia protocol. What they've been doing for a number of years is giving R-CHOPs times 6, and at the end do a PET scan. If the PET was negative, no further treatment. If the PET is positive, they give radiotherapy. So it's not randomized, but PET guided protocol. And what they reported is that the PET positives, that's the green curve, did very well if they received radiotherapy, but if they didn't receive radiotherapy, they did very badly. And the PET negatives were reasonably well. But remember, we were talking about outcome in the 80s in the Unfolder study, for example. We are here seeing outcome in the 70s. So what this study doesn't tell us is if these PET negative patients received radiotherapy, how much improvement that curve would have shown. So it shows that the outcome without radiotherapy is not that bad, but it doesn't show if radiotherapy improves things or not. And if you wanted a further comment on this, Andrew Worth and myself wrote a commentary in the same issue of Blood on the same study. So this is what we do in clinical practice. I mean, this is a good example of a 73-year-old male, diffuse large B-cell lymphoma, bulky stage 2A. So a site of bulk and then few nodes scattered below that. And he had R-CHOP chemotherapy and had CMR. And the question is, should we give him radiotherapy or not? So the considerations is, well, he is 73. He just managed to get R-CHOP 6 with difficulty, probably is not going to be a candidate for salvage and stem cell transplant. But the disease is between the kidneys. So is radiotherapy here safe or not? Should we give it or not? And the answer is simply this. If you can give safe radiotherapy, if you have the technology to give safe radiotherapy and avoid the kidneys like here we are avoiding the stomach as well. then you should actually, you're not losing anything. The cost benefit analysis is in favor of giving radiotherapy in this case. So just to mention the skeletal sites, this is a retrospective analysis from the German group where they looked at skeletal sites receiving radiotherapy or not receiving radiotherapy, and they found a significant difference in EFS, but not significant. There was a difference in PFS, in overall survival, but not significant. So interesting outcome. Testicular, just for the sake of completion as well, it needs a talk on its own right. One of the things to comment on is that we are seeing more testicular involvement with PET staging than ever before. I think if someone looks into it, we will find that testicular is more common than what we used to think in the past. But the ILSG study some time ago now showed that those who had scrotal irradiation had much less scrotal relapse, contralateral testicular relapse, than the rest of the population. Now moving on to early stage diffuse large B-cell lymphoma, and things used to be easy and straightforward, but it's not that straightforward nowadays. So this slide is before 2018-19. So we used to say there are two options. You can give R-CHOP times 6 only if you prefer to avoid radiotherapy for whatever reason, or you can give short course of R-CHOP, typically 3 plus involved site radiotherapy, and they give you the same oncological outcome, but they give different toxicity. So it's a choice of toxicity, not of outcome. And the combined modality offers the benefit of less cardiotoxicity and less hematological toxicity. Then, and this is just an example to show the British guidelines, which still talks about combined modality treatment for early stage lymphoma. The basis for this was the SWOG study that looked at CHOP times 8 versus CHOP times 3 plus radiotherapy. So this was chemo alone policy. This is short chemo plus radiotherapy, and there was a significant difference in the initial publication. And as a follow-on, they when rituximab came along, they did a phase 2 study. That's the blue curve, with the addition of rituximab to the same regime, compared it to the historical, and you can see exactly the same shape of the curve, but better outcome reflecting rituximab benefit. So that establishes R-CHOP times 3 plus radiotherapy. Very good outcome, difficult to think it can be improved upon. Then in 2018, 2019, a couple of publications came along, a French study and a German study. This is usually known as the LAMI study. This is usually known as the FLYER study. And what they did is they tried to look at, can we use PET to give less R-CHOP, and can we not give radiotherapy? So now the options for early stage look like this. It's a bit complicated. If you use the original protocol, if you like, you can just say, okay, any stage 1 or 2 non-bulky, you can give 3 R-CHOP and radiotherapy. Or if you want to follow the LAMI study, then you have to select stage 1, less than 7 centimeter masses, less than 60 years of age, performance status 0, and normal LDH. Really, really very good prognostic group. And then you give 4 R-CHOPs. If any of these are positive, you give 6 R-CHOPs. And then you do a PET scan after 4, and if it's CMR, you stop. If it's PMR, you give radiotherapy. And in the study, that was about 14% positive. The FLYER study used age less than 60, IPI of 0, and LDA, stage less than 7.5 centimeter bulk, and stage 1 or 2. And it gave 4 R-CHOP versus 6 if the PET scan was negative, and again showed good result. But the problem is the complexity of the eligibility criteria. And if you look at the LAMI study, and you look actually who at the end following this protocol got only 4 R-CHOPs, not 6, you find it's about 48% only got the 4 R-CHOPs, and the rest got either 6 or 6 and radiotherapy. And you have to ask the question, really, how much better this is compared to the 3 R-CHOP and radiotherapy, which is easy and straightforward. But there are certainly options. Now, moving on to the incomplete response to chemotherapy, but that we mean something like this. So this is a baseline mediastinal mass that after R-CHOP, there's a very good response, but residual area like this here. In general, we try and biopsy these, but it's not always possible. And this is the kind of response that you might add radiotherapy instead of adding salvage chemotherapy and stem cell transplant. Now, the question really is, what's the outcome from chemotherapy? And that's usually like that from R-GEMOX in relapsed diffuse large B-cell lymphoma. So radiotherapy has a better outcome in these situations. These are retrospective series, but the event-free survival in similar situations is about 65% up to 90%. And the question really is, do these patients really need stem cell transplants? This is our own data that we presented in ESTRO a couple of years ago, where we looked at patients who responded, but they're still PET positive with DVIL 4 or 5 after our chemotherapy, and we had 43 patients. The PFS was 72% for these patients after radiotherapy without any chemo. And the overall survival was 78%. And when we look at what happened to them, about 50% of them achieved CMR after radiotherapy. Moving on to more recent treatment, CAR T-cell therapy. It's kind of introducing a slightly different role for radiotherapy in those situations, and better illustrated by an example. So this is one of the earlier patients we treated, actually. So you get this kind of story. This is a 51-year-old fit businessman, double hit diffuse large B-cell lymphoma, had 4 lines of chemotherapy and relapsed, and now had leukapheresis for CAR T and waiting to have it. It's kind of its last hope, because he never had a response that allowed him to get into a transplant, and he failed harvest before. And then just before getting the CAR T, I apologize for the picture, a shocking picture, but just before getting into CAR T, his neck mass involved the skin and started to fungate and bleed, in fact. So you get an urgent phone call, and what we've done is we did not want to delay his CAR T treatment either. So we gave him 20 gray and 5 fractions as a quick holding measure, and then he went on to have his CAR T, and that's the response after CAR T. He relapsed a few times after this, but never relapsed in the neck. And in fact, the other sites of relapse, he relapsed 3 times in other places that were managed with chemotherapy usually fails, and then further radiotherapy. So intriguing. But the question really is, this is being labeled, that use of radiotherapy is being labeled as bridging radiotherapy, which is kind of you're trying to stabilize the disease and control the symptoms to allow the treatment, the ultimate treatment, which is CAR T, to be given. So it's a bridge to another treatment. So why do we think of radiotherapy? Because most of the time we are at a stage where the disease is completely chemorefractory and nothing would work. But there's also some other rationales, including that there is evidence that debulking reduces relapse and reduces toxicity and improves local control. There's some attractive theories behind the interaction as well, which is that the radiotherapy can increase T-cell trafficking and tumor infiltration. It sensitizes tumor cells to CAR T, and it can overcome the antigen escape, which is one of the mechanisms of failure of CAR T. So just to give 1 or 2 examples of these, some early studies suggested higher bulk is associated with increased relapse, and a couple of examples here. You will notice they are quite small studies, but they are just really raising the issue for further testing. So if you had lower bulk, the relapse rate was higher. Similarly, the higher bulk was associated with increased toxicity, and this is again another analysis where the patients who develop grade 1 and 2 have lower bulk typically than patients who develop grade 3 and 4 toxicity have higher bulk. Another one from the Juliet study looking at the bulk, and there's a difference in toxicity between higher bulk and lower bulk. One of the other points is actually this study has just been published in the Red Journal now, so you can read the study in more detail. And they added more lesions. I think there are 350 lesions now and more patients. Most of the relapses involve original sites, so it supports the addition of local treatment to the mix. The radiotherapy for CAR-T is very different from our usual radiotherapy. There is usually time urgency because the disease is progressing, and there is usually urgency in terms of we do not want to delay the main treatment, which is the CAR-T. So we need to fit in. So 3 or 4 week courses may not be that attractive. We do not need to give very high doses to control the disease long term, because CAR-T is the ultimate treatment. You sometimes just need to give a holding dose of radiotherapy. And the volume does not need to be covering all sites of disease. You may just cover the site that's causing problem. The example I've just shown with the neck, this gentleman had disease elsewhere, but the neck was the site that's causing problems. And therefore, we need to process the planning and the whole pathway quickly, but still be careful, because a third of those patients will have a long survival and they may get toxicity. So what we try and do in our own institution is, if we know that a CAR T cell case is being referred, we usually referred really by a phone call or an urgent email. Then we book them for a few things on the same day. That's assessment and consent, mask if they need, and a CT scan, and then we do the contouring on the same day, and we try and turn around a plan approval within a week and start within a week. In the UK, we are planning to start a REMIT study in the next month or two, and this study is looking at building in bridging radiotherapy immediately after leukapheresis with a couple of weeks window, usually between day -30 and day -15. And the idea is that we're trying to think as well whether, if we have a site that requires your typical dose of 20 to 30 gray, does it also benefit the patient to add 4 gray to other sites? And so that's a protocol where it had full dose to one area and low dose to other areas. And we are also testing if this high dose one or full dose one should be guided by measuring the metabolic tumor volume. In other words, to be bulk related. So just a couple of words also on the radiotherapy we practice nowadays, in case we have some non-radiotherapy colleagues attending. Radiotherapy obviously has changed significantly in the last few decades. Now we treat smaller volumes, we target the lesions in a much better way, we use lower doses, and we use advanced techniques that would protect the normal tissues. So it's more accurate and safer. And the progression, we started with total nodal radiotherapy, mantle and inverted Y, to involved field, to involved site radiotherapy now. And these pictures of mantle that irradiated, if you look, this is the same patient with the mantle picture, but also on her surface, you can see how much of that breast, this part of the breast, was irradiated, and that what caused breast cancer in the old days. Or if you extended the field for the upper aortic and spleen, it also covered the whole heart. Nowadays, we really treat smaller volumes in a very targeted way. We also use deep inspiration breath hold that moves the diaphragm and the heart lower down, and sometimes creates that very useful little gap between the target and the heart, which allows us to avoid significant dose to the heart. It also allows us to use a narrow margin around the target, and therefore reduce the tissue irradiated. In our institution, we do not prefer to use VMAT for mediastinal disease because of the low dose bath that will go all around, covering the breast and the lateral lungs. And we use what is being labeled as butterfly VMAT, which delivers the dose from the center of the chest to avoid the breast and the lateral lungs. And the way it's delivered is 60-degree arcs from the front and the back, same way, but divided in two. And again, 60-degree arc from the front again and the back again. So we do not go through the lateral part of the chest and the breast. Then the bed will rotate and we'll do a craniocaudal arc, sup-inf, and then inf-sup, again treating from the middle of the chest, not through the lateral part of the chest. And the combination of not using wide field but smaller volumes and deep inspiration breath hold, and also butterfly VMAT, even for mediastinal lymphoma, has meant that we now moved from doses to the heart in that region with that level of expected major coronary artery events down to kind of that level, for example, where the expected increase in cardiotoxicity is very little. In the abdomen, again, imaging and the ability to fuse PET-CT and do CBCT is quite helpful. If I look at the bottom panel first, I mean, this is an original mass, and it left a residual mass here after treatment. It's PET negative, but we decided to treat this for bulk. And one of the things we can do nowadays is outline the residual mass, as you can see here, and also outline the original volume using the PET and treat to two dose levels, higher dose here and then slightly lower dose to the outside part here while protecting the kidneys. And one of the problems with these, so that's an example of treating this without treating the kidneys. One of the problems with abdominal masses is they move with the degree of gas in the colon. So this is the planning CT. The left side of the colon was full of gas, and that's the target we're treating, and the mass here. And on that particular day, the colon was completely empty of gas, collapsed, and the mass just flipped to the left side. And you can see that it's outside the volume. And it's the daily CBCT that we use that gives us confidence that we're not going to hit the target if you use this on that particular day. So in summary, is systemic treatment enough? I think we discussed that there's room for improvement because there are about 30 to 40% relapses still happening, and salvage is not as effective as it used to be. We also looked at the cases where the radiotherapy might add benefit in diffuse large B-cell lymphoma, and we also looked at the toxicity of modern radiotherapy and the age group that we are looking at. So I think that in these cases, the balance is in favor of giving radiotherapy to improve the outcome. And I'll stop here and take any questions.